Well, it depends on the severity of the illness, how many ear infections the child has. Is the infection continuous, not responding to antibiotics? Do they have chronic fluid in the ears because of the infection, which leads to hearing loss? Usually when the pediatricians send the children in to see us, it's because the frequency or the chronicity of the infections are long enough that we talk about first putting tubes in their ears. The advantage of tubes is that it gets rid of any hearing loss that they have, and it helps reduce the number or eliminate ear infections. Our goal is to make the child's hearing as normal as possible by enough time until they outgrow the problem. Most kids will outgrow this, especially as they get closer to teenage years, so we know that this is a temporary problem, and our job is to keep them as normal as possible until they do outgrow it. There are numerous studies showing that children who grew up in households of smokers are sicker than children who grew up in households of non-smokers. So I tell parents or grandparents, look, if you can't stop smoking, go outside. Keep the house smoke-free. That way you don't pressure the child's immune system into getting into situations where the child is sick strictly due to the fact that you're smoking. I think most parents will recognize sleep apnea in children, except that they're very, very young. But most parents recognize it because they hear their child snoring, and they go in there to listen, and they hear the child stop breathing. Sleep apnea is the worst form of snoring because the airway totally closes off. So I always ask my parents when they come in is, does the child snore? And if you're hearing snoring, do you hear them stop breathing? The stop breathing episodes will last 10, maybe 15 seconds at the longest, and then the child will gasp and start to breathe again. If they hear that on a regular basis, then we're highly suspicious for sleep apnea. And the treatment for sleep apnea in children is reduction of the tonsils and the adenoids. Their studies show that curing sleep apnea in children is as high as 85% by taking out tonsils and adenoids, where in adults it's only about 50%. So the disease is different in children and is more curable in children than in adults.
Further, in general, most children that we see don't need additional tests. Just by looking at them, physical examination and clinical history is enough to be able to determine whether or not we need to proceed on with the adenotonsillectomy. Some children, it's different because you can look in there, their tonsils aren't very large, and they may have large adenoids. In those cases, there are two different studies that can be done. I offer most of my parents, I can either do an x-ray, we can get an x-ray to look at the adenoids, or if the parents don't want them to have any of the radiation exposure, or if they want to know the answer right now, I can also do a scope and put a camera into their nose and look at the adenoids and visually see whether the adenoids are large. And if those are large, with small tonsils but large adenoids, you can still have episodes of sleep apnea. If both the tonsils and the adenoids are small, then what we would proceed next with would be a sleep study to check, actually, to see if they measure with sleep apnea while sleeping.
And children don't tend to have as much sinus disease as adults. It seems to be much worse in adults. Traditionally, most of us feel that sinus disease in children probably is a factor of either allergies and or hypertrophy of the adenoids. So you usually see if somebody has chronic sinus disease as a child, the first thing that we would be evaluating is the size of their adenoids. That would be number one. If the adenoids are large, then recommendation certainly would be to take them out. Long-term use of nasal steroid sprays are another effective way of treating the allergic end of chronic sinus issues, and if that fails, then what Dr. Wright was talking about, x-rays to help confirm that there is sinus disease, and then the balloon sinuplasty is a nice intermediate step. The aggressive use of sinus surgery in children has decreased over the last 20 years because they find that there are less invasive ways of doing it and accomplishing the same thing.
I also do maxillary balloon sinuplasty with irrigation. That's kind of a modified type of a sinus surgery. I think that for children it's a nice intermediate step before proceeding on with formal sinus surgery. I can also do formal sinus surgery in children. I personally think that if it was my child though, I would push towards more of a intermediate step and not a full-blown sinus surgery, mostly because it doesn't violate the children's sinuses. That's something we definitely can offer here.
There are some children that, are very, very timid, they're very difficult to work with. We have ways around that, okay? And you have to modify how you treat the child, depending on the personality, what kind of experience they have. We try to reinforce to the parents when they come in that we don't do shots. Kids are used to go to the doctor and there's a shot, there's pain. And I try to reinforce to the parents, no, we don't do shots here, there's no pain, all we really do here is look. Whether it's with a bunch of variety of lights and telescopes and flashlights, we try to calm the child down by reassuring him that they're not, or her, that this is not a painful condition, that it's a look.
Sometimes we need to clean some ears, and when I do that, I always have the parents hold the child, because I think a lot of examining the patient is really a lot of parent-child interaction, because the parents make the child feel comfortable, so that's very important. I've always had an affinity to work with children, and especially now that I'm a mom, I feel like I can really relate to the parents when they bring their children in here to be seen for ear problems, throat problems. My own children have had tubes. I've had one of my children has also had his adenoids out. So I know what it's like to be on the parent standpoint of handing your child to a surgeon to say, take care of my child, because I've been there. So I love working with children because they're so fun, and they bring life into every practice.
Being older than Dr. Wright, I've gone through all the kid years already. My kids are grown, but certainly throughout my career I felt the same way. Kids are great. You hate to see children suffer. I think that's universal, that either being a parent or even a non-parent, nobody likes to see kids suffer.